Thank you all for joining us today and good afternoon. I'm Beth Stewart, and on behalf of the Texas Oral Health Coalition, welcome you to today's presentation entitled Screening, Brief Intervention and Referral for Treatment for Patients with Substance Abuse Disorders, presented by Dr. Simmi Patel. Dr. Patel's presentation is provided in part by a grant from HRSA, the Health Resources and Services Administration for Rural Communities Opioid Response Program, planning to assess prevention, treatment, and recovery resources to address substance abuse disorder, specifically opioid misuse and abuse, in the rural areas of the Texas Golden Crescent. A consortium of community stakeholders developed collaborative and sustainable plans to address rural substance-related morbidity and mortality. This initial consortium grew to establish a community-led, recovery-oriented system of care called ROSC. The ROSC named the Golden Crescent Recovery Initiative a growing network of clinical and non-clinical organizations whose overall goal is to reduce morbidity and mortality from substance use by improving prevention, treatment, and/or recovery services. This course will focus on the substances or drugs abused in Texas and introduce screening tools for use in practice to determine if patients have substance use disorders, how to initiate a brief intervention, and then provide referral sources for treatment. Dental providers may earn 1 hour of continuing dental education credit for submitting the completed online evaluation. I am pleased to introduce you now to our presenter, Dr. Simmi Patel. Dr. Patel currently works as a clinical assistant professor in the Department of Public Health Sciences for the Texas A&M School of Dentistry and graduated with her Doctor of Dental Surgery degree from the University of Texas Health Sciences Center in San Antonio School of Dentistry in 2001. In 2021, she received training to become a certified tobacco treatment specialist and is currently a fellow in compromised care and hospital dentistry. Dr. Patel has over 22 years' experience providing dental care to patients, many of them from vulnerable and at-risk communities, specifically in the Dallas Metroplex shelters, serving patients who are homeless, victims of domestic violence, victims of sexual trafficking, recovering alcoholics, and drug addicts and inmates. It is with great pleasure that I give you Dr. Simmi Patel. So thank you, Dr. Patel, and the controls are all yours.
Okay. So I want to thank the Texas Oral Health Coalition for hosting this lunch hour presentation on screening, brief intervention, and referral for treatment for patients with substance use disorders. I also want to thank the Texas Oral Health Coalition for keeping the water in Dallas fluoridated. They did such a great job. We almost lost fluoride. And that's something very near and dear to my heart. On this screen, it has my contact information. Feel free to jot down my email address in case you have to leave and can't ask your question. But I wanted to show you, I wanted you to appreciate on this slide, that is the crystallized form of methamphetamine. And I just wanted to show you what it looks like. So the course objectives are to familiarize dentists with the top drugs abused in Texas, introduce some screening tools for use in practice, determine if your patients have substance use disorders, initiate a brief intervention, and provide referral sources for treatment. And then, as Ms. Stewart had mentioned, this project is funded by a HRSA grant, the RCOR psychostimulant support awarded to the Texas A&M School of Nursing. So the top drugs abused in Texas, there are 3 DEA offices, field offices in Texas. One is Houston, and the other one's in Dallas, and the other one El Paso. And you can see methamphetamine is number 1 in all 3 territories. Number 2 is where it starts differing. Houston, where it's cocaine, and Dallas and El Paso are heroin is high. And then third, it's also different for all three territories. We're going to, this presentation isn't going to go into marijuana use. We're going to focus our presentation on those psychostimulants since they're the top three. So we start with methamphetamine. Orally, if you take it, it'll take about 2 to 3 hours to take effect. It can, if you take it intravenously, snort it, or smoke it, obviously it's going to be faster. But I want you to appreciate that it stays in your body for 12 hours. So this is why it's the most commonly abused substance in Texas. It's cheaper than cocaine. It's pretty easily made. Like it comes, from Mexico in liquid form, gets converted to the crystalline form in the dry houses on this side of the border, on the Texas side. And it's done inexpensively, but you can see that who wouldn't want to be on a high for 12 hours? So if you look at the timeline for methamphetamine, it was first synthesized by Japanese chemists in about 1893. Then a Japanese chemist in 1919, who, by the way, also trained in Germany, crystallized it. And this is important to know because it was used during World War II by the German soldiers, Japanese pilots. In 1938, right before the World War II, that's when the FDA made it a prescription drug. But it was used to keep soldiers alert, keep those that were, injured out of pain, and prevented them from being tired and thirsty. It was in the 1960s when the U.S. finally deemed it a social problem. So heroin in Texas, the picture on the right is black tar heroin. That's the most common form of use in Texas. Half-life is 30 minutes, and just want you to remember that the half-life is not when the drug is eliminated from the body, but when the concentration is half the original dosage. So that doesn't mean it's going to be in your body 30 minutes. It can be in there for a longer period of time, especially because it gets broken. One of the metabolites it gets broken down into is morphine. So it can last you can be on a high for a while, but not as long as methamphetamine. So then we have fentanyl, which is, growing popularity, and that's used to be mixed in, or what they call cut in other drugs. It's metabolized by the liver. The half-life is 3 to 7 hours. And, from what you probably have heard in the news, it just takes a little, and you can have a lethal amount. Then we have cocaine. The onset of this is like within seconds, by the way. The half hour is about an hour. And you have to understand that the vasoconstriction that you endure with cocaine can last hours after use. However, the popularity of it is going down because it is more expensive, way more expensive than methamphetamine. And then we have our pharmaceuticals, our hydrocodone or Vicodin as an example, and oxycodone or like OxyContin. Half-life of hydrocodone is 3.8 hours. Oxycodone's a little bit less, 3.2, but I would imagine it's pretty much the same, 3.2, 3.8 hours, probably negligible difference. The onset of action is 10 to 20 minutes, and the peak effect is about 30 to 60 minutes after you take a hydrocodone or oxycodone tablet. So this, many of you probably remember this scale when you were visiting a family member or a loved one in the hospital. They used to have this on that dry erase board. It used to bug the heck out of me because after surgery, how realistic is it for you to have zero pain? And so this is when we saw the market rise of opioid prescriptions. And pain was used as that fifth vital sign, which really did not help with this opioid epidemic that we're currently experiencing. So in a study, U.S. dentists often prescribe more than the recommended quantity of opioids for pain. They were more likely to prescribe stronger opioids. And there was study-reviewed research on approximately 550,000 adult dental visits between 2011 and 2015 before the CDC set guidelines. The guidelines were that that they recommended that the use of NSAIDs for acute pain because it was more effective. And then over 50% of the prescriptions for opiates were longer than the 3-day supply recommended by the CDC. And approximately 29% of patients were prescribed stronger opioids than needed considering the procedure performed. So I'm going to go over a study. So this was just released in January 2024 of JADA. And they basically looked at all the prescriptions that about 200,000 dentists wrote. And it was like a total of 320 million prescriptions, but out of those 320 million prescriptions, 70 million were for opioids. And so they looked at the trajectory from 2015 to 2019. And while they did see some decrease in opioid prescribing behavior, it went down by 34% over this 4-year time period. They did find out that there was, I'm going to go to the next slide. They did, the study is important because it's a longitudinal study. And they found that those that were high prescribers, that, they divided dentists up by rapid decliners, those that were prescribing high in 2015 and rapidly declined by 2019. Then they, the non-prescribers like me, moderately high prescribers and high prescribers. And what they noted was that 3.4% of dentists were continuing to still prescribe high rates of opioids. And they were also more likely to prescribe more than 3 or 4 or 7 days worth of opioids. And, that if you look on the right, they categorize it in what we call morphine milligram equivalents. And as dentists, all we need to really know is if you're prescribing, so morphine milligram equivalent is your total daily dose by this, it's a equation, total daily dose, the strength of the dose, and then there's a morphine milligram conversion factor. And anything above 50 and 290 or greater, that person is more likely to have it doubles their risk of having an overdose. And so if you look, I hope you can appreciate, this is the end of the study in 2019. So one thing that you can appreciate is that the rapid decliners, a lot of them were participating in Medicaid, and Medicaid had changed, their reimbursement. Basically, they weren't reimbursing for opioid prescriptions. So you could see that went down a lot, which is good. But then the prescriptions to adolescents, in my opinion, continues to be high. And then the morphine milligram equivalent is greater than 50, which, it should be an eye-opening factor for all of us. And the higher prescribers were a combination of general dentists and oral surgeons. That's what they identified in this study. So then in about 2023, the ADA released an article, and this really caught my attention because I was a little confused, but I totally understand it. I totally get it. Screening by dental care professionals can represent an important and sometimes sole step in curbing problematic drug use. And that's what we're finding in our practice. So the ADA also says when it comes to the medical history, patients may not feel comfortable disclosing that they're using opiates, Suboxone or methadone. Adverse outcomes may occur if a proper medical history is not obtained. Some drugs may affect your postoperative instructions. Medications or drugs may interact with anesthesia. Some drugs may affect dental treatment or other health conditions that the patient may have. And then it's the dentist's ultimate responsibility of the dentist to obtain, maintain, and review a patient's medical history. So what are some of your screening tools that you have in your office? And I'd say the best one to start with is when your medical history form. So while you have that open, um, you may consider changing your form if some of this isn't on there, but always ask if there's a family history of addiction. Start with your past, current, and current tobacco use. And I always ask quit attempts. How many times, have you tried to quit? And if it's like one or two, I say good for you. I always try to, because I want them to understand that they've done it in the past, and they can do it again. And we all know with any type of addiction, it's a chronic disease. And so it may take multiple attempts for them to stop using. When it comes to alcohol, then we start with tobacco, because barely, most people don't have a problem going over tobacco. Then we go to alcohol, and I would ask them, and I'm going to show you how we do it at A&M on the next slide, so it kind of makes sense. But basically for females, if they're drinking more than one drink a day, and men more than two drinks a day, that may be a red flag. And we probably should go into another questionnaire called the CAGE questionnaire, which doesn't take that long, and then offer referral for treatment. And then when it comes to prescription drugs, I always ask them, this is how UT Southwestern trained me. Have you used a medicine in any matter from which it was prescribed? And then the patient usually goes, what do you mean? And so I'll say, for example, when you had a back pain or a toothache, did you use your mom's prescription? Did you have to have you ever used someone else's prescription pain medication for that? And then that's a good way to ask that question. And I want to remind everyone, we should be asking every patient, because dental operatories are such that they're, fairly open. Um, um, and, one patient usually can, hear what you're asking the other patient. And that way people don't get offended when you're asking one person over not asking another. So I always say, ask everyone. And that destigmatizes substance use disorders, which is what we're trying to do. Is we're trying to get people to open up about using substance use. And then in our practice, we always do a depression and anxiety screening, and I highly encourage you to do. It's like 2 questions. If you email me, I can send you those questions. But any positive response on those, we have a mental health counselor in our community clinic, and they automatically get a referral, because it's important that get treated at an early stage and not wait, to where it gets worse. So at A&M, how do we do the questionnaire? So we have an iPad, and before we even do this, the dental assistants in our community clinic are so awesome. They know all our patients, right? So, because when we have the students come in, they don't know our patients as well. They have a rotation maybe for a week, and so that it's really hard for them to get to know the patient as well. But the assistants, the same 4 faces, have been there for years, and so the assistants usually do the questions first with the patient while they're getting them ready for the appointment, and then we go in and we ask the same questions again. And so we have an iPad, and we start with tobacco. Have you ever smoked? Do you currently smoke? How many times have you tried to quit? And then we tell them we have a free tobacco counseling program, and we can give them free medication. Are you interested? And if they're interested, I'll give them a sample of when I say sample, it's actually the whole thing, and we're not taking tablets out, but we can give them a sample of those Nicorette lozenges, and then we schedule them an appointment, and we schedule them a counseling appointment at the front desk, and I do the counseling with them. So then we use the same questions, and then we ask for alcohol. Have you ever used alcohol? And do you currently consume alcohol? A lot of times if they say, yeah, I consume it socially, that's great, because then you can say, well, how many drinks would you have in one sitting? And because remember, binge drinking is also a red flag, right? For substance use, maybe a substance use disorder. So, that's a good time to take the opportunity. How many drinks would you have at that one setting? And if some of them say, it's common for them to say, yeah, I drink, on the weekends or during the week. And I'll say, well, would you drink 20, would you say you drink 20 drinks in a week? And they're like, oh, no, not that many, maybe 14, which is still, we were talking about for females, more than 7 drinks a week, and, males, 14. I mean, kind of getting in that territory where we probably need to have that chat. And there, we have a questionnaire for alcohol too. And then we go into the next question after alcohol is, then we'll go into prescription drugs. Have you ever used a medication other than the way it was prescribed? And then the final question will go is into recreational drug use. Like, do you use marijuana, cocaine? And, we'll go through methamphetamine, we'll ask them. So the whole point of this questionnaire is not to expect a positive response the first visit, so that, that article that where, we could be the sole the sole provider at curbing substance use. What they're trying to say is these people get very comfortable with you, and what we've noticed in our practice is over time, people are coming forward. So they may not tell you the first time, they may not tell you the second time, but by the third or fourth time, they're starting to open up and let us know that they've had a previous history with alcohol addiction, or that they're, currently using heroin. We've had positive responses this way. So that's why it's important to ask every time. So this is if the alcohol use seems quite disturbing, I would say, or kind of have a little bit of an alert, in my mind that they may be using more than they probably should, then I'll go into this questionnaire. Have you ever felt like you should cut down on your drinking? Have you ever been annoyed when somebody criticizes your alcohol use? Have you ever felt guilty about your alcohol use? And then have you ever had to take an eye opener or something to treat a hangover? Any positive response, you probably want to implore further and, do like a brief intervention. Some red flags, and of course, these aren't going to be all, I'm sure we can all come up with, additional 10, but, previous history of addiction, we know it's a chronic disease. I would say alcohol and tobacco use together. We know that there's certain certain personalities that are more impulsive, and they are highly likely to abuse other substances. Mental health, any anxiety, depression, other psychiatric conditions. That's why we have that depression, anxiety screening, because we want to get it early so that they're not, at the later state where they're more likely, more vulnerable. Their disposition, are they behaving erratically in the waiting room? Are they asking to be seen immediately? What is their behavior that day? Multiple surgeries and chronic pain. We see this a lot where a patient has back pain and they've been on hydrocodone / acetaminophen for, years, and develop an addiction. And then dry mouth, worn dentition, rampant decay, of course, and then cross addiction. We're seeing that a lot of our patients abusing substances, they'll say, well, I use heroin, but I refuse to give up marijuana. So they're trying to, I want to get clean on heroin, but I want to continue using marijuana. We know that, trading one substance for another is not going to help them in recovery. So we want to also be mindful of some of the language we use around patients or with each other. I would say let's get out of the habit of using some of these words, because we want to destigmatize addiction. We want these people to come forward. When we have this attitude where the person has a weak moral character and that's how they got an addiction, people aren't going to come forward, and they're less likely to ask for help from you. So we don't want to use words like meth mouth, because it's not the methamphetamine causing tooth decay and dental problems, but it's the lifestyle changes. If you're on a 12-hour high, you're on that high carb diet, you're not brushing your teeth, you have decreased saliva, you're grinding, it causes you to grind your teeth. And then, because when it's smoked, we are seeing that enamel destruction. So what we do is, those people who are methamphetamine and not ready to quit, we'll remind them to set their alarms on their phone, so that they can hydrate and brush their teeth, to remind them to brush their teeth. So what is a brief intervention? A brief intervention is when we go in, and first of all, I always thank our patients for sharing with me that they have an issue, or that, yes, I am using methamphetamine, I'm using heroin. I always thank them for sharing. I always ask them, have you tried to quit before? And anything where that, yes, and I stay clean for this, and I'm like, well, good for you, because you can do it. Where we kind of run into issues as dentists is we belabor that the negative consequences on their health. We talk about it so long, but what we should be using, I'm not saying you definitely go over that, but don't spend a whole bunch of time on the negative consequences, because what we need to utilize on the brief intervention is motivational interviewing, because sometimes brief intervention can be standalone treatment. And I'll give you an example. When we give those lozenges to patients for tobacco cessation, I can't tell you, I think I've had at least a few patients say, when they come back, I'm like, well, you never made it to counseling. Like, I gave you the lozenges, and they said, because I didn't need it, I quit. Those lozenges helped me quit. And you talking to me that first appointment, that was enough. Or it will help engage the patient if you for a higher level of treatment. So when I do motivational interviewing, it's open-ended questions like, how do you feel about your drug use? Tell me more. How does your family feel about your drug use? Tell me more. This is where we're doing more active listening. And if the patient is saying, well, I'm not going to quit, marijuana, and then you just kind of reflect it back. Well, you don't want to quit marijuana because it makes you feel good, and you keep reflecting back, because it's kind of like what we call sustained talk. And I would like to tell you that the Mayo Clinic, UC San Diego, they all have good webinars on motivational interviewing, and it's something I think all dentists, it's an eye-opening experience. When I was introduced to motivational interviewing, I realized that the way I interacted with patients, it was more like me instructing them, but it now I notice I'm listening more. I'm doing more active listening. And we want to let the patient know that we have resources to help them with substance use, for treatment. And we want to let them know that we're, whenever they're ready, we're there to help them too. So if they say they're not ready, we're not going to force them into treatment, but we want them to know that we're there for them. So then we'll do a warm handoff. So that's when you want to make sure you have those referral sources and names of providers ready. So on the next screen, I'm going to kind of go over the best place to go. So SAMHSA, .gov, so it's findtreatment.gov, has this place where you can look for facilities, and you see I've Googled Amarillo, Texas, within a 25-mile radius. So I did a search for the Golden Crescent, like that, in particular Victoria, Texas, and I found two. My patients are in a community clinic. They might not be able to afford treatment. So I Googled, when I did my search, I made sure to look for the treatment centers that accept grants or state funding, federal grants, things like that. so that they could help our patients that aren't able to afford treatment. So for example, like in Victoria, you have the Billy T. Catan Recovery Outreach Center, and then you also have the Gulf Bend Center. So, and I'm sure there's multiple other ones, but as you notice, if you go into rural areas, you may have a harder time finding these treatment centers, but SAMS has done such a great job to let you know who has grants to help patients pay for these, treatments, because a lot of them, they'll say, I can't afford it. And that's, what they're worried about. So this is a great resource. Keep it on your desktop. And then you can just print, the map, and I would even call that center when you do that warm handoff. Don't just let them leave without, calling and seeing if you can schedule an appointment. So of course, the treatments available for substance use, there's Suboxone, which is buprenorphine and naloxone together in a 4-to-1 ratio. It's a Schedule 3 drug. It's a sublingual delivery. It's a film, that they put under the tongue. One thing about that for dentists that we need to know, important fact, is that the sublingual delivery can lead to a swollen or painful tongue, redness of the tongue, and numbness of the oral cavity, and even vomiting. Methadone is still used. It's a Schedule 2 drug, but one thing is they have to be careful in cardiac patients. It does also cause more respiratory depression, and it can cause ventricular fibrillation. So what I suggest and the CDC does suggest too, is if anyone on Suboxone, methadone ought to have the next thing, which is naloxone available, because people on Suboxone and methadone are highly monitored, but if you have children in the home and the Suboxone or methadone gets in the wrong hands, you probably need to have that. You should have that Narcan available. It's a reversal agent to reverse the effects of Suboxone or methadone, and it's added to buprenorphine to decrease IV abuse, and it's a lower duration of action. And with all this, of course, none of these work alone. You need, just like with tobacco counseling, you need behavior therapy or counseling. It's essential to help with substance use disorder. So the next slide, it's going to be very helpful to all of you, especially if you're in a rural area. If you need naloxone, we were talking about this. There's a link and that you can get some free naloxone. So feel free to copy that link. I wanted to play this video because I hope we can appreciate how our opiates can get in the wrong hands. This is a child. She went through a purse. And so, it doesn't take long for them to get into things that they're not supposed to. It doesn't take long for our teenagers to do the same, to try things that, they've heard about. And, we can also thank social media for some of that. So if you go to this is how we order ours, naloxonetexas.com, and it'll say, you can say it'll say click on get naloxone or click on free training. Feel free to do either one. It'll ask you to fill out a form and you can get some free naloxone. We were talking about this because we've gone to different drugstores and some of us have had a hard time finding it over the counter since it's been approved to be OTC. And then I got a picture of one the other day from one of our providers, and they found it at Target for $45. You get a 2-pack. I'm not sure all our patients can afford that. So that's why if you have the same issue as I do about affordability, get on there and go ahead and order you some. So when it comes to dental treatment, this is what I recommend. If somebody comes in with acute pain, try to see if you can take care of it the same day. Let's address that chief complaint instead of, hopefully we're not doing this, but I've definitely seen people do it And the emergency room for sure does this, but the antibiotic plus narcotic is not. It's outdated. We should not be doing that. Try to, if I can treat that pain the same day, that's my goal, to avoid, substance use. I don't want to create substance use disorders. So that's what we're going to do. And for patients with a history of substance use disorder, consider your choice of local anesthetic. At the end of that treatment, I'm reaching for that bupivacaine which is 0.5% with 1 to 200,000 epinephrine. It's been working really well in our patients. It can last anywhere up to 48 hours. So I like to put it in there because when I call that patient that evening, a lot of times they're like, I don't feel anything still, which is great. And especially if you have someone who can only take acetaminophen, and they can't take the NSAID, then I'm going to put the bupivacaine in. And then, evidence-based data shows that ibuprofen at 400 milligrams plus acetaminophen at 500 milligrams is superior than opioids alone for management of post-op dental pain. And then we talked about if the NSAIDs are contraindicated, then you can recommend 1,000 milligrams of acetaminophen, but just remember your maximum dosing. So that's when you want to go ahead and put the bupivacaine in. Another thing is, that's when the ice packs are good. 20 minutes on, 20 minutes off. That's going to help with the inflammation as well. But the bupivacaine is awesome. We call it, and the other thing I would tell you to do is if like I did a surgical extraction or did an alveoplasty, I go ahead and call the patient before I leave that evening. And we've noticed when I started calling patients before we leave, or if I can't do it, the staff calls them. And we noticed when we started calling these patients, they're not coming in the next day in a lot of pain. In a lot of pain, we're not having a lot of post-op visits, so that is definitely beneficial because we're able to handle it, on day one. If you have to prescribe an opioid, a few recommendations. You have to check the pharmacy website before prescribing. Make sure you check it because you want to make sure they're not on other opioids. You want to make sure they're not on other things like benzodiazepines. So make sure you check it. Make sure they're not getting it from other providers. We're not doctor hopping. Also, if you're going to prescribe an opioid, prescribe the minimum effective dose that you need to achieve pain relief. I want you to see if you can definitely avoid just in case dosing. That's not helping. If you're going to prescribe an opioid and NSAIDs are not contraindicated, go ahead and add NSAIDs. Go ahead and add your 400 milligrams of ibuprofen. Maybe you'll decrease your acetaminophen to 325 because your opioid will have your opioid will have a NSAID usually attached, and that could be at 325. But if you're going to prescribe an opioid, don't prescribe more than 3 days is my recommendation. The other thing is go ahead and prescribe Narcan. We saw in that video that it doesn't take long for it to get in the wrong hands. So I would go ahead. You don't have to prescribe Narcan. I'm sorry, it's over the counter, but go ahead and recommend Narcan. And that's why I'm asking you to order it. Go ahead and order you more than, for your emergency supply kit. And that way you can give it to those patients. If you're going to continue writing prescriptions for opioids, go ahead and order yourself some Narcan that you can give to the patient. Also, a lot of our students didn't even know this. Avoid prescribing chlorhexidine in our patients recovering from alcohol addiction. It's about 11% alcohol in there. It will cause them a relapse. So please, please, please avoid Paradex in our patients recovering or anyone recovering from alcohol addiction. And this is when on these patients with substance use disorders, I try to get phase 1 treatment done. And then I'm going to do everything to get them to transition back to society. A lot of them can't get jobs when their front teeth are, so badly decayed or missing. And these are things that we have to keep in mind, is that we want to help them transition back. And, we have to help them, by first we do the phase 1, but then we need to try to get them in to finish treatment and maybe at the end we have to just build them that dentures, in a, you know, uh, and I don't want to say expedite because it's denture appointments are not usually expedite, but we want to help them get back into society. So we need to consider how are we going to get them there? Because they are looking for jobs. They are trying to transition back and how do we do that? And finally, I'm gonna open it up. I think we have like about 15 minutes left for questions. So I want to make sure we have enough time for all of you to ask questions.
Okay, well, thank you, Dr. Patel. And we do have some questions. One is, would you share the resources for motivational interviewing? And you can send that to me. We can add it to your webpage
Sure.
for your webinar, and then also we can send it out to our attendees today. If you can send that to me. Let's
Absolutely, I
see.
can do that. Yes.
And then another question, are iPads more secure than the patient's cellular device for these surveys?
Okay. Yeah. So I can just tell you from an A&M standpoint, it's been set up by our IT staff. So even though we're in a community clinic, the A&M IT staff has made sure that all that information is secure. So it just depends. You have to check with your IT person, but ours was set up by our A&M IT staff. Everything has to go through them.
Mm-hmm. Okay. We'll give a minute for anybody else to, if you'd like to ask your question verbally, you can raise your hand and we'll unmute you, or you can unmute yourself. I had a question like from the beginning, one of your first slides, when you were going over the different the different drugs, meth, heroin, fentanyl, and my question is about fentanyl. Does it cause like liver disease since it's processed in the liver? Does it
That's
end
a
up
good
causing?
question.
Yeah.
Yeah, that's a good question. Yeah, that's a good question for a lot of these substances. We're finding that a lot of our patients are having, getting hepatitis and uh, you know, all kinds, yeah, liver issues, but then also kidney issues. Because some of these, a lot of these drugs are being mixed with other substances. So we are seeing increases in liver issues and then also kidney disease. So that's also something you have to keep in mind when you're, uh, you know, making recommendations for pain management. You have to really that's why I always say the medical history is key. We had a patient, he was so jaundiced, his eyes were so yellow, and kudos to the student for figuring that out because he had checked no on everything, or he said his wife did it, but checked no on everything on the medical history, and she's like, Dr. Patel, the eyes are yellow, his eyes are yellow, and he's been in the ER 12 times. And so yeah, we are finding that a lot of these medications are, yes, they do cause liver issues.
Yeah. And I've even had a patient not tell the truth about having hepatitis C.
Yes,
After treatment was all over and all that, and then a couple appointments later down the line, they confide that, oh, they're Hep C. So you never know.
you never
Um,
know.
Another question, if you suspect that the patient may be under the effect, what is the course of action? Would you avoid treatment or any particular anesthetic?
Okay, yeah, it depends. We have this, I don't know if you guys are having this in your clinic. We're having a lot of patients come in and you could just smell weed on them. You could just smell that they've just, I mean, that smell is pretty easy to detect. And we ask them and they'll say no until they're blue in the face. I would tell you something like that, be very careful. You could approach them and ask them, keep asking them and they could keep saying no. but don't use epinephrine, whatever you do. If you you can smell weed on them, don't use epinephrine. On your opiates, I'm very I'm just very blunt. I'll say if you've used um any substances within the last 24 hours, you could die in my dental chair. And I think um when you put it in that, um you tell them those type of consequences, they're going to come. Usually most of them don't want to die in a dental chair. And so, yeah, I tell them, if you've used it within the last 24 hours, we cannot treat you. I mean, absolutely no. And then that's when they usually say, well, I used it 12 hours ago or something, and then we'll reappoint them.
What about alcohol? If they come in just reeking of alcohol, and you can tell they've had several drinks before they've come in to help with the pain, so they say. Um, do you still give epinephrine? Do you still give your normal treatment?
We've had that happen. So uh, the students and myself, we usually pull that person aside and we talk about, being responsible as the patient responsibility, being responsible as a patient. And we'll say it appears as if you've had a drink. And uh, they've usually come forward and said, yes, I was at a wedding reception. I mean, it's weird that you're at a wedding reception on a Tuesday, but I mean, more, but we're happy that they're coming forward and at least admitting it. And then we tell them that we don't want them to make dental decisions under the influence, and then we do reappoint them. So I'm just very straightforward. If we smell it on the patient, we do talk to them about it. We try to do it as gently as you can. And just say, look, sir, it does appear that you've had something to drink. And you can deny it, but it's hard to hide. We can smell it on you, and we try to talk in a low voice. And for the most part, people have come forward. We just haven't really had anyone, especially when we explain the consequences, of making a decision under the influence. They usually are amenable to rescheduling their appointment.
Okay. Let's see. Catherine made a comment that I would also work toward developing great relationships with your support staff. Often the patients will say something to a dental assistant or others that they wouldn't say to the dentist. And that is true. Um, let's see. We have another question. Any alternatives for Paradex for patients with alcohol abuse or in recovery?
That's a good question, Yafet. So yeah, there's, Paradex is, remember, FDA approved only for gingivitis. So you could use Listerine Zero, keep with some Listerine Zero in your office. There's no alcohol in there. And that's what I use every day because, boy, when I was at like college age, I used to use a regular Listerine and I hated it. It burned so bad. I was so happy when they came up with those zero alcohol or alternatives. So I'll say keep those, um, uh, you know, a rinse. It may not be just as good as chlorhexidine, but at least you won't get the staining, and it is something at least. But yeah, definitely avoid that Paradex.
Right. Let's see. Any other questions, comments? Here's another question. If you suspect that the patient may be under the effect, oh, I think we already asked that, didn't we? Yeah, I was scrolling up. Any other questions? Anything else that you would like to ask Dr. Patel? Any comments? Okay. Well, thank you so much for this informative presentation. I learned a lot. I learned a lot today. So,
Thank you so much.
yes, it was very, very good. So thank you. Did anyone else have any last parting questions or comments they'd like to ask Dr. Patel? I see a lot of excellent informations and thank yous. Well, Dr. Patel, we thank you again for your time and this really nice presentation. Have a wonderful afternoon and a nice weekend. So thank you all again for attending our webinar today.
Thank you, everyone.